Very good morning, everyone. Welcome to the breakfast at UMHealth session on this Wednesday. First of all, I would like to apologize for the slight change in the order of our presentation today. The vascular surgeon is going first today. And my name is Shanggar. I'm from the Department of Surgery, and I'm here to moderate the session to be presented by Dr. Ahmad Rafizi Hariz on the topic of endovascular aortic aneurysm repair, also known as EVAR. Dr. Hariz, you all might have heard about him. He's our senior consultant vascular surgeon who actually has rejuvenated and given life to our dormant vascular services in PPUM upon his return from UK. He has brought many innovative approaches in managing highly, as we all know, vascular cases are quite morbid and high mortality. So he has done very well in managing all these morbid cases. He will be elaborating on one of those techniques in complex aortic aneurysm management today. So I won't delay further and invite Dr. Hariz to present his topic. Hariz, the mic is yours.
Okay, thank you, Prof. Shanggar, for the kind introduction. First of all, apology for my voice. I've been not really that well, after traveling in a few countries. But anyway, I'm going to talk about EVAR, EVAR, endovascular aortic aneurysm repair. There's a diverse audience out there. I've given this talk in the recent Aortic Asia, but I think it's a bit too advanced, so I'm just tone it down a bit and then give a bit of theory for those medical students as well. All right, so let's crack on. Okay, I think we all know
this is share the screen first, Hariz.
Oh, sorry. My apology. I'm told I only have 25 minutes, so all right, is it okay now?
Yes, we can see the slides.
Okay, right. So we are now in the, okay, so basically short history about the AAA. I think it was started back in 1920s where they all ligate the aorta. Of course, we all know the outcome. And then we all know about Albert Einstein, where he also died of AAA where he ruptured. After this, the first repair of, and then the cellophane wrap become infected, and then eventually they come out with this a new technique in 1955 to open repair and then just replace with the inlay graft. And then in 1990s, I think I'm quite fortunate to have a picture with this father of EVAR, Wan Parodi. He invented the stent graft to treat the AAA back in 1990s, and then we move on from there. So just a bit of theory for those medical students out there. So basically AAA, I think we all know that it's just a dilatation of the aorta more than 1.5 times the normal size. The size is about 1 to 2 centimeters. It's often asymptomatic, mainly in stator fighting, and it's common among the elderly and smokers. And once it rupture, it's going to be very high mortality. I'm sure you all know, the clause where if the patient rupture at home, only 50% of them will make it to the ambulance, and among those on the ambulance, 50% will only reach the hospital. And once in the A&E, 50% will go to the OT. All right, so that's how this disease is. So that's why we advocate repair when it's reached its threshold, which is 5.5 in male and more than 5 in female, or the nature of the pathology features of the aneurysm, whether it's pseudoaneurysm, sacculum, or microtic. And we do often offer open repair for fitter and younger patients, but for those who are a bit more elderly and have pseudobacteriotomy, we offer EVAR. Having said that, it's quite expensive, so they have to be funded, and then we do quite routinely preoperative imaging, CTA for all our patients. And most of the time, we do see infrarenal rather than juxtarenal or suprarenal. But having said that, we do see them quite often too. Okay, let's just move on. Okay, so this is just a treatment algorithm. I think this, I don't really need to elaborate more about this, but having said that, the rupture risk, I think it actually increased with the size of the AAA. As you can see here, I mean, if it's reached more than 5.5, okay, so rupture risk can go up to 10%. So this is when the open repair risk is actually less than the rupture risk for the patient. So that's why we advocate open repair. Okay, so how about open repair versus EVAR? So at the top here, you see the open repair scar, elective scar. You see how we repair it with a bifurcated graft there. So you've got a long scar. Okay, for a young patient, it's quite tolerated, provided you got a good ICU care and as well. But if you see, this is EVAR. At the bottom here, you get these two small little scar. All right. So that's the difference. Okay, I think most of my patients actually want EVAR. Okay, so just a snapshot about the comparison. I think for EVAR, even though that the treatment looks great and all that, but having said that, even though that it has lower 30-day mortality, but the re-intervention rate is a bit on the high side. It's about 20%, and it needs surveillance lifelong, where the open repair doesn't really need surveillance lifelong. As you can see here, this is the longest trial for EVAR versus open repair. We have an EVAR 1 trial from UK, about 1,000 plus patients, and they follow up to 15 years. As you can see, the blue line, the open repair line actually surpass the EVAR line here, okay, when it reaches about 12 years. So otherwise, it's more or less the same for this patient, right? Okay, so EVAR has been there for quite some time, and it has actually evolved. Okay, we got the first generation stent, second generation stent, and even now third generation stent, as you can see here. And we also have adjunct to this technique. We have anchors, we have chimney stents, we have all these other sort of tricks that to actually help us to implant the graft properly so that it won't cause any endoleaks. All right, and also we have, my unit, we are moving towards more and more complex repair, where we do nowadays more and more fenestrated EVAR, where we put multiple side branches into the visceral vessel, like as shown in the pictures. Okay, we can treat more and more suprarenal and also thoracoabdominal AAA. Okay, so I move on to the topics that I've mentioned just now. So sac embolization. So for starters, I think I just want to highlight that the Achilles heel of EVAR is actually endoleak. Okay, endoleak is actually the leaking from the side of the stent graft. So if you don't implant the stent graft properly, it can still cause leaking, and then the sac will still enlarge, and then eventually it can rupture. So we have multiple types of endoleaks as is depicted here. We got mainly type A, and type 3 is the one that is quite dangerous, where it's high flow. Type 2 is the low flow, where it's from the backflow from the vessel, from the lumbars or from the IMAs. Okay, and re-intervention rate is quoted about 10% post-EVAR due to these issues. Okay, so there's a few studies that look into this type 2 endoleaks. Okay, one of the studies here mentioned that when they follow up these type 2 endoleaks, actually from those, probably about a quarter actually have type 1 and type 3 with the high flow endoleaks. So there is a occult type 3 endoleaks, and this eventually lead to re-intervention and also lead to rupture. So is there a role for this preemptive sac embolization? So we actually did a few literature review, and then a few papers out there, started back in Italy in 2013, where they actually embolized the sac, non-selective. It's an industrial cost about 1,000 to 3,000 ringgit, and also fibrin glue, which also costs around there. So they put about that much of coil, about 3 coils, and then they see the patient. So basically, in conclusion from this study, is actually a valid approach, and actually it reduced the re-intervention rate. Okay. This is from the study. As you can see here, it reduced the re-intervention rate, especially in those patients who have a site diameter more than 5.7 centimeters. Moving on to further studies, I think this is from France, back in 2015. So what they did was they also embolized the sac, as you can see here. And as you can see, the mean coils that they use is 12 coils. So you imagine 12 coils, one coil is roughly about 2K to 3K. So that's like the EVAR stand itself, the price. So it is very expensive, this procedure, even though that they are just using it to actually prevent type 2 endoleaks. But having said that, it's quite effective. As you can see, before EVAR and after EVAR, the sac size actually reduced. And further studies, this is also from, let me just have a look. Oh, this is another study from Italy, where they also still using the same technique, and they found that is also quite beneficial in a longer term follow-up. And from this another study for sac coil embolization regarding type 2 endoleak, this one, they actually recognize a few factors that relate to high-risk type 2 endoleaks, like 4 or more patent lumbar arteries, or big IMA more than 3 mm, or floor lumen diameters more than 3 centimeters on the pre-op CTA. So in this cohort of patients, they advocate non-selective coil embolization. And this is the outcome, as you can see here. For those high-risk group, is very beneficial. For those high-risk group without coil embolization, as you can see, the re-intervention rate is very high. Okay, and then for those who are low-risk group, which they didn't do coil embolization, their outcome is more or less the same as the high-risk group with coil embolization. So we do note about this. All right. So this is when they follow up those type 2 high-risk group. And then as you can see here, more than 90% of them has increase in the sac size, and then almost all of them actually required re-intervention with any form of methods, right? And then the most recent study is from this Stephen Holland group in France. It's my idol. He's actually quite prominent figures in vascular surgery, especially in the endovascular region. So basically, he published this RCT where also he non-selectively coil embolized using also industrial coils, very costly. As you can see here, about 10 coils were used. In each patient, of course, they have good outcome at 24 months. Having said that, 10 times 10 coils. So, I mean, the cost is quite humongous. But anyway, this is just some of the data from that study where they mentioned that the fluoroscopic time is not more or less not really that different. Okay, and then the re-intervention need, of course, the sac embolized group fare better, and the sac size also more or less reduced. Okay, so move on to what we have our experience in UM. So I'm just going to show some of the evolve of this treatment, what we call Malaya technique. All right, so we started off with the peripheral pseudoaneurysm, where we have some maybe iatrogenic pseudo from a vascular access procedure, where it was described by Belmont in his study to embolize with industrial grade coils. So of course it's quite expensive. We use that. So what we did was we used this off-label use of these wires actually, where we remove the outer coils, outer core, and then we actually just use the outer core, the helical outer core, because it's very floppy. So this cost, just for almost 3 meters is only probably about 60 ringgit. So that's not expensive at all. So we can actually use this in this situation. So what we did is what we've done. So basically we just percutaneously puncture the aneurysm sac, and then we just put these coils and then leave the tail outside the skin like that. So we can do this either under fluoroscopic or ultrasound guided. So after probably 3 to 4 days, so this is the removal of the coils. After we check with the ultrasound that the pseudoaneurysm actually resolved, then we just basically remove the coils. So as simple as that. So by doing this technique, we found it super beneficial where we no longer actually need to do open repair of peripheral pseudoaneurysm. We either can just compress it. If failure of compression, we just do this Malaya technique, and then it works. Unless it's an infected pseudoaneurysm, then we still have to do open surgery because we can't put any foreign material. So as you can see in the video there, so the coil is fully removed and the pseudoaneurysm is thrombosed. Okay, and we also evolve this technique to management of endo leak, where we sometimes got referral from other centers. After a few years, the patient developed endo leak after the EVAR, and then we treat that with this technique as well. Okay, and then I have published this in the European Society of Vascular Surgery meeting. It's quite some time ago, in 2016 actually. So what happened was it's quite efficient in the sense that it induced sac thrombosis, and all sacs actually regress in terms of diameter. Okay, so it's quite good. And then from there we move on to I just want to show you some example of the treatment. So this is one of the patient post EVAR where has as you can see just now, that's the type 2 endo leak. So you see the contrast at the back of the stent graft. So what we did was, under fluoroscopic guidance, we puncture it biplane, and then we get into the sac from the back. So we do the sacrogram like that. So inject a contrast, and you can see actually the flow within the sac like that. So, and then we just pack it with coils, and then that's how it looks like. It looks very messy, but it's effective. And then this is just like maybe a few $100. So it's super cheap as well. Okay, so we also did this for TEVAR. TEVAR is thoracic endovascular aortic aneurysm repair. So we did this for descending aorta as well. As you can see in the video there is a type 2 endo leak from the sac at the chest level. So I think just let the video play, and then yes, you can see that endo leak there. Okay, so we just percutaneous puncture the sac as well. As you can see, there's the intercostal vessel that feeding and drain to the sac. So we just put loads of coils into that, just pack it. Okay, and then this is a post-op 1 month CT scan. So basically the sac thrombose off, and endo leak settle, and then the sac regress. So it's also useful for endo leaks management. So we move on from there to actually prophylactically use it to prevent endo leak. So this is our experience. We started off back in 2017 until 2020, just a prospective series comparing non-Malaya. This is just a demographic data setting as well, and also a myocardic aneurysm as well. Okay. And this the outcome. So basically, you see endo leak quite high in this Malaya group. Why? Because this Malaya group, we did quite a number of them actually chimney EVAR, where you will definitely have a gutter endo leak. But having said that, you see re-intervention rate is almost zero with the Malaya technique, whereby in the non-Malaya technique, we still have to intervene later on. Okay, so just some case examples. So what we did, this is quite elderly with the incidental AAA. So that's the CT scan. So I'm just going to go through this quite fast because of the time limitation. So it's quite big AAA, maybe about 7 centimeters there. So this is the angiographic finding before we stent. So as you can see, very angulated neck. So sometimes they can, the stent won't really stay there. All right. So this is okay. So what happened is we put the wire into the sac first before we deploy completely the stent graft. So that's the stent graft deployed, and then this is the procedure where we put the coils within the sac. As you can see here, very nicely put in the sac. All right. So this is how it looks like. Very messy. You don't really see the stent now, but when we do the angiogram, so the contrast just flow within the stent. There is a type 1A endo leak there a bit, But over time, I mean, over a period of time, it actually resolved. So we actually extended the stent actually, and then they're still there. The type 1A embolic, and this is CT scan at 1 month. You see the stent actually, the sac size regress, and it's okay. And we move on. This is a mycotic AAA. Mycotic is an infected aneurysm, all right? So they can have due to, in our region, mainly due to mediodosis. We do see them quite commonly. Salmonella is one of the other bugs that commonly affected the aorta. So they come in with pain, with fever, unexplained fever, and then we did a scan and then show all these things. So normally, if they don't have any rupture, so we keep them in the ward because they tend to rupture. So in case they rupture, we just go in and then do open repair. But if they can tolerate, I mean, they don't rupture, what we do is normally we just give them high dose IV antibiotics, monitor them. Hopefully we can so-called sterilize the sac. And then after 2 weeks, we treat them with EVAR. So this is how it looks like. We also use Malaya technique in this setting as well. So that's the pseudoaneurysm of the aorta. So this is how it looks. CT scan. Reduce nicely there. There's no endoleak, and then CT scan down the line. That's 1 year, and this patient is actually on lifelong antibiotics. That really further reduce, and as you can see, it's more or less become normal already. Okay, how about ruptured AAA? So we also employ this technique in the ruptured patient as well. I think fortunately this patient, it is only from another hospital in KKM. So he came there, offered open repair because 80 years old. They refused. Actually, he came in with leaking. As you can see, there's a lot of hematoma there. Rectal peritoneal hematoma. For those who haven't actually seen a ruptured AAA on the CT scan, this is how it looks like. There's a lot of hematoma there. All right. So 80 years old and with the history of previous laparotomy for PGU repair, you don't want to actually open it. All right. So in this patient, fortunately, the vital sign was stable with permissive hypotension, transferred to our center, and then we managed to do EVAR for him. So this is how it looks like. Let me just play. So we did the same thing, stand, and coil and Malaya technique. So that's the post-op CT scan. And then this is at 1 year CT scan. So we did this under local anesthesia. Nowadays, we can do EVAR under local anesthesia as well, provided the anatomy permits it. Okay, so this is a 1 year CT scan. Maybe I can just forward. Okay, so that's the stent. Okay, so that's the sac, the coils inside there. As you can see, you don't really see the huge sac anymore. You don't really see the hematoma in the retroperitoneal area anymore. So that's how good EVAR and Malaya technique can be. Okay, so recently this year we have even more complex challenge where we have a suprarenal mycotic AAA, where it involves the visceral vessel as well. As you can see, involve the right renal, the left renal, even the visceral. So it's going to be super difficult to actually stent this vessel without causing any ischemia to the organ. So what we did, I mean, because if we order the fenestrated stent graft, it took us at least 6 weeks for the custom device to be manufactured. So what I did was just a chimney EVAR and parallel EVAR. So after a few weeks of IV antibiotics, so this is how it looks like on a pre-operative CT scan. So as you can see, pseudoaneurysm, huge pseudoaneurysm with impending rupture. As you can see, a bleb there. Okay, so we went in. So it's involved the both renal artery. So let me just go next. Okay, so that's the, and so we did the Malaya technique. As you can see, I put a coil, I put a wire there to stand by for the Malaya, and then what we did was we put stents into the right renal, into the left renal, into the SMA. So this is how it looks like when we deploy the stent. Okay, so those are the visceral stents, and then eventually we put the aortic stents there, and then we coil the sac, and then this is how the end product end run looks like. So as you can see, the contrast flow nicely into the visceral vessel and also into the renal vessel. Okay. Okay, this is the post-op CT scan. So sorry for the slowness of the. Okay, so you can see select there, the SMA, the renal stent. You see the sac is almost not there anymore with the coil inside you. On all the renal stent, everything is patent. All right. Okay, so I think that's about it that I wanted to share. So as a conclusion, ladies and gentlemen, is there a role for preemptive sac embolization during EVAR? For me, no and yes. Basically, no if there is a minimal thrombus or thrombus lumbar or IMAs and a flow lumen diameter neural thrombus. And if we want to use expensive coil, I think it's a no-no. But if we employ this Malaya technique and then you have all those high risk factor, many lumbars, big IMAs more than 3 mm and also minimal neural thrombus, I think it's quite a useful thing to do because I think, based on my presentation earlier, I've already proven that Malaya technique is safe, cheap, and effective, and also is minimally invasive technique to treat peripheral cerebral aneurysm, endoleak, post-EVAR and TEVAR, AAA, ruptured AAA, and even mycotic AAA. However, having said that, I think with the mid and long-term outcome, I do know the mid-term already, but the long-term outcome still unknown. So hopefully, for those listening, maybe the biomed or the engineering faculty, maybe we can collaborate and then think about future technologies where, we can invent something like a super large or long detachable coil, or maybe incorporate this technique into the stent itself with preloaded wires and catheters. So, just time will tell. So with that, I would like to thank everyone for listening and your attention. Thank you very much.
Thank you, Dr. Hariz, and hearty congratulations to you for the introduction of this new technique in the vascular services named Malaya technique. And also thanks for sharing it with the audience today. So we have a few more minutes. I think we have 3 minutes before we pass over to the next team presenting. If anybody has got any questions, I don't see anything in the Q&A section there. If anybody has got any questions, you can either type it there. I can read it out for you for Dr. Hariz to address. In the meantime, maybe I just ask you the Malaya technique when you insert the catheter, isn't it? It's a sheath of the like a catheter.
It's the coil. It's a coil. It's actually just what do you call it? A guide wire.
Guide wire.
Just a simple guide wire.
And then the blood drains through around the guide wire into a drainage bag, is it?
No. The guide wire basically the function is like a coil. So basically we just put the guide wire. I made it into a floppy because I removed the inner core and then just pack it into the sac, and then it actually augment the thrombosis.
Okay. So it just acts as a coil.
Yes.
Okay. So you won't get any drainage because you punctured and all. You don't have any leak from the puncture and all that. You don't get those kind of complications.
Yep. Okay. But having said that, I think this is still outside IFU indication instruction for you. So so hopefully I can publish this technique, and then it'll be good.
Yeah, I know that you're already in the map of vascular services in the world, so I hope you can just get this published.
I think recent presentation, I think all the other even the Westerners also was like asking. They're quite surprised now. But all in all, it's good outcome. So
great, congratulations to you, and hope we will see more of you in the international arena. Okay. All right. So with that, I think since we don't have any further questions, I think I will hand over to the next team who is from the anesthesia department. I think.